Hi, good evening, good afternoon, everybody. Good morning, wherever you are. Welcome to this webinar by the International Academy for Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint-Ouen Hospital in Paris, in France. It is 6 p.m. in Paris, 6 p.m. in Utrecht, 5 p.m. in London, and noon in New York. And today's webinar is dedicated to a fascinating disease, namely Waldenstrom Macroglobulinemia. It's very puzzling, orphan, highly neglected disease for many years, but over, I would say, the last 5 years or so, we've seen tremendous progress and also drug approval, which is quite unique in such an orphan condition. And we all of these advances to some new developments in the understanding of the pathophysiology, the role of BTK inhibitors like ibrutinib, zanubrutinib, and many others. But we also owe this to the hard work and efforts of top experts like our guest speaker today, Professor Monique Minnema, who kindly accepted to deliver a state-of-the-art comprehensive overview on how to diagnose, but also how to manage Waldenstrom macroglobulinemia. So Professor Monique Minnema is a professor of hematology at the University Medical Center in Utrecht in the Netherlands. And since her early years, she specialized in the diagnosis and treatment of plasma cell dyscrasias like multiple myeloma, AL amyloidosis, but also our topic today related to Waldenstrom. She has also, I think, led the guidelines in some of these rare conditions, like, for instance, Big Neil syndrome. So, Monique, welcome, and thank you for dedicating some time to this webinar. It will be an interactive webinar, so please don't hesitate, as usual, to post your questions, your suggestions, your comments. And at the end of the talk of Professor Minnema, I will be back and we will discuss all of these issues together. But for the time being, I would like to invite Professor Minnema to deliver her lecture. Monique, the floor is yours.
Hello, my name is Monique Minnema. I work as a hematologist in the University Medical Center Utrecht in the Netherlands. And I'm thrilled that I was asked to talk to you about Waldenstrom's macroglobulinemia, because I think this is a very fascinating disease. So thank you very much, the International Academy of Clinical Hematology, to include this disease in your presentation series. I would like to discuss some aspects of both diagnosis and treatment with you all. I think Waldenstrom's is a fascinating disease, and I always like to talk about it because besides it's a rare disease and has some very distinct presentations, it also has many variables in its presentations, which makes it fascinating, but also the different treatment-related side effects it has compared to other non-Hodgkin lymphomas make it a very special disease. I think the hallmark of this disease is that Waldenstrom's is a bone marrow cancer, and like other non-Hodgkin lymphomas, it shares some common presentations, like B symptoms, and especially fatigue can be very severe in these patients. Nodal disease can be present, but at diagnosis, it's less than 20% of patients, and many patients do have splenomegaly. So that's common with other non-Hodgkin lymphomas. But what's very different in this disease is the fact that the lymphoma secretes an M protein, and therefore you can have very much M protein related side effects, such as hyperviscosity, autoimmune effects, because the M protein can bind to the anti-MAG, can have anti-MAG properties and bind to myelin on your nerves, and that can cause neuropathy. But it can also bind to the I antigen on your red cells, and therefore cause hemolysis, such as in cold agglutinin disease. The M protein can form cryoglobulins, and you can have typical patterns of that, but also it can form fibrils, and then you have AL, IgM amyloidosis. So it's a very diverse pattern in that aspect as well. And the last striking thing about this disease is that there are several immune effects related with Waldenstrom's. For example, you can have a very low hepcidin in your blood, and that can also cause anemia. You can have Schnittler syndrome, and that's a skin disease in which you have urticaria that can be very itching, and they can only resolve when you treat the Waldenstrom's. But I won't discuss those in this session. Perhaps another time talk more about these fascinating aspects. But in this presentation, I will talk about the rituximab flare and rituximab intolerance. That's also very typical in Waldenstrom's disease. What's also striking is the name of this disease, because in many hematological cancers, we don't use the names of the founders of this disease anymore, but in Waldenstrom's it's different. So the name was given to the disease by Jan Waldenstrom, who discovered the disease, and Waldenstrom's macroglobulinemia is defined as having a LPL, so a lymphoplasmacytic lymphoma in the bone marrow biopsy, combined with an IgM monoclonal protein. So the WHO pathology book can only classify lymphoplasmacytic lymphoma, because that's what you see in the biopsy of the bone marrow. But when it's combined with the serum, with the IgM protein, you can diagnose Waldenstrom's disease. And the previous name of LPL was immunocytoma, and sometimes you still see this name in some literature. Importantly to recognize is that when you detect in the serum of a patient a non-IgM protein, you can't discard Waldenstrom's completely. In most cases, these patients will have multiple myeloma, but be aware also non-IgM lymphoplasmacytic lymphoma does exist, looking a lot like Waldenstrom's, but per definition, it's not. And also the other way around, if you have an IgM protein in your bloodstream, you can't conclude it's Waldenstrom all the time, because also IgM multiple myeloma exists. So please do perform a core biopsy of the bone marrow, because then you will know the exact clone that's underlying your M protein that we can easily see as clinicians in the bloodstream. Unfortunately, we do have two separate classification systems at the moment. One of them is the WHO HEM5 classification, and the other one is the international consensus classification that both have been published at the end of last year. In the WHO classifications, there are two subtypes of lymphoplasmacytic lymphoma, and the most common being the Waldenstrom's phenotype. So you have LPL in the bone marrow and a IgM protein in the bloodstream. But also the other type, which I also just mentioned, the non-Waldenstrom type LPL is there. I think it's around 5% of all patients, and it does include cases with an Ig or an IgA protein, but with an LPL in the bone marrow biopsy, but also non-secretory LPL and IgM LPL without bone marrow involvement is now presented in this classification, but I think the last one is quite rare. In the ICC, they make the distinction between LPL, so Waldenstrom's disease, but also and between MCUS. In the WHO HEM5 classification, an IgM MCUS is classified as having less than 10% of an infiltration in the bone marrow, but the ICC states that only when you have abnormal lymphoplasmacytic aggregates being less than 10% in the bone marrow biopsy, you can also already have Waldenstrom's disease. So that's a very very clear distinction between the two classification systems. And I do hope that one day we can go back to one classification system in the near future, because I do realize this is quite confusing to patients, but also to clinicians. In general, as already stated, Waldenstrom's disease, or LPL, is a very rare non-Hodgkin lymphoma. On the left, you see a chart of all the more common lymphomas that there are, diffuse large B-cell lymphoma being one of the most frequent lymphomas, and LPL is around 1 to 2% of all B-cell non-Hodgkin lymphomas. The female to male ratio is 4 to 6, and the median age at diagnosis is 70 years. Between 2000 and 2010, the median overall survival is still improving, but was around 8 years. And there's one prognostic scoring system for this disease, and that's the ISSWM, which has to be applied before starting treatment in any patient, but also at diagnosis. And here you see all the variables of this prognostic score. This score was published in 2009, so already quite some time ago, and it was deducted from 587 patients, and the variables were advanced age, above 65 years, your hemoglobin level, your platelet count, your beta-2 microglobulin. So also in Waldenstrom's, you have to assess the beta-2M, not only in myeloma, and having an M protein above 7 grams per deciliter. They identified low-risk patients, about 1/3 of patients, intermediate-risk patients, with 2 points or only having an advanced age, and 3 to 5 is high-risk patients, also 1/3 of patients. And on the right, you see the survival curves. And what's striking is that, for example, in the high-risk patients, the 5-year survival rate is only 40%. And this is not fitting current survival curves anymore. So I think the IPSS is still, the ISSWM is still worthwhile, but the estimates of survival are not up to date anymore in the current treatment landscape that we have for these patients. Because here you see a graph from a more recent paper. This was published in last year, and this is data from the Dutch Cancer Registry. And here you can see also years from diagnosis. And for example, if you look at the high ISSWM score, so that's the green line, so at 5 years, it's more around 75% survival compared to the 40% that I just showed in the previous slide. So much improvement has been made in the survival of these patients in the more recent decades, thanks to, I think, better diagnostics, but also better treatment options. And in this paper, you can also see some other nice graphs about the different diagnostic years that were present, and also the relative survival curves that are improving. If you go to the top 3 slides, you can see different time periods, and the green and the orange one is being 2003, 2010, 2011, 2018. And you see there's much improvement from that point on, not only in younger patients, but also in patients being 66 to 75 years, and also in patients above 75 years, albeit they still do have the worst relative survival compared to the younger groups. And we do think that especially the introduction of rituximab in the early 2000s has contributed a lot to that, but I think also the newer ones with BTKIs will be very important in this. But also the relative survival, 5 years, 10 years, and 15 years has improved in all diagnostic age groups. So it's very important that we maintain this kind of registries to see and to have a more clear understanding of this disease, but also to help our patients a bit better in their prognosis and to give them hope that their disease can be treated. A very typical aspect of Waldenstrom's is also the familial predisposition. It means that it's not a genetic hereditary disease, but it's striking that 20% of Waldenstrom patients do have a first or second degree relative with a B-cell lymphoproliferative disorder. So that can be Waldenstrom's, but also CLL, Amicus, or other non-Hodgkin lymphomas. And we still don't really understand how this is happening, but 1 of 5 of your Waldenstrom patients will have will have a first or second degree relative with another type of lymphoproliferative disorder. So that's why it's very important to do a family history with your patients to see if there's such a phenomena occurring also in your patients. But being said, this is not it's not a call to do a family screening in these patients, because we do see that the risk is still low, and also that we don't have curative options for the patients. So that's why we are not advocating for screening of family members of Waldenstrom patients. So in the diagnosis, it's essential to do a bone marrow biopsy. And I would strongly recommend also to do multi-parameter flow cytometry, immunophenotyping when you do a bone marrow biopsy, because it really helps you to detect the typical aspect of Waldenstrom's disease, and that is that besides a B-cell clone, there's also a plasma cell clone to be detected. So you have 2 types of clones that are in the bone marrow biopsy, and that makes Waldenstrom's very different from other types of lymphoma, and especially marginal zone lymphoma, which can be very difficult to distinguish between each other, and they look a lot like each other. So if you look for the B-cell clone, the phenotype is CD22 DIM expression, CD25, CD27, and IgM positive. And in most cases, a negative expression of CD5, CD10, CD11C, or CD103, but there are cases with CD5 and CD23 expression, so look out that you don't discard this diagnosis completely. And when you type for the plasma cells, it's striking compared to myeloma. That's, of course, you have a light chain isotype expression, but these plasma cells have, besides they are CD38 positive, they are also CD19 positive and CD56 negative. And in myeloma, most patients are CD19 negative and CD56 positive. So also in that regard, you can distinguish it very clearly from a myeloma disease in Waldenstrom patients, in which you have a very large portion of plasma cell component in the bone marrow. And of course, it's important that there's the same restricted light chain expression, so kappa or lambda, in both types of clones to make the diagnosis. But I think the most important aspect of diagnosis has been the discovery of the MID88L265P mutation that is present in mostly all Waldenstrom patients. So I think everybody has to test for this mutation when you suspect the patients of Waldenstrom's or marginal zone lymphoma, because it can distinguish the two. I think in the beginning, we also stated that in marginal zone lymphoma, there can be MID88 mutations, but perhaps these were misclassified in beginning. So I think at the moment, it's very clear that having this mutation is a very, very high suspicion for Waldenstrom's disease. Other genetic abnormalities of this disease are the deletion 6q and trisomy 4. And in most patients, we do not perform cytogenetic analysis, but perhaps in the future, this will become more important. Another frequent mutations in Waldenstrom patients are the CXCR4 C-tail mutations. So they occur in the C-terminal domain of this part of the gene. You have different types of mutations. You both have nonsense and frame-shift mutations. And importantly, multiple CXCR4 mutations can be present within one patient. So it's not that easy to test for these mutations because it's not one mutation like what's happening with the MID88. It's just one mutation, so you can develop a PCR for that. And that's why I think in not everyday life, CXCR4 mutations can be present. But we do advise to, when you're considering to give a Bruton tyrosine kinase inhibitor, such as ibrutinib, zanubrutinib, or acalabrutinib, to test for CXCR4 mutations because they are associated with less sensitivity, and less duration of response than patients without these mutations. And that's especially occurring for the nonsense mutations in CXCR4. Recently, the European Consortium of Waldenstrom's Macroglobulinemia published a paper in Leukemia 2023, where you can read about all these recommendations for Waldenstrom's diagnosis. And so they state that a bone marrow biopsy is mandatory. Bone marrow aspiration samples has to be done to perform a multi-flow cytometry and the molecular studies. You can do that in a non-fractionate bone marrow aspirate, also for the MID88 mutation assessment. But if you want to do CXCR4 testing, then CD19 enriched samples are to be advised. So to conclude the diagnostic part, there are some do's and don'ts in Waldenstrom's disease. So IgM M protein is sometimes difficult to quantify in patients, and especially if you want to look for progression or response if you are treating those patients. So it's more easy to follow the total IgM levels of your patients, and also the formal response assessments are being done on total IgM levels. To measure those, perhaps in addition to your M proteins, to have a clear view of your progression or response assessments. And do not measure free light chains because there are some papers they are not adding to the diagnostic value in these patients, except of course when you have IgM related amyloidosis, then the free light chains are important and are the most important ones to reduce when treating patients. Another very important aspect is that in Waldenstrom's disease we do a CT scan for evaluation of splenomegaly, of lymphadenopathy, and not a PET-CT scan, which is normally done in other types of lymphomas. And that's because the PET-CT does not add any diagnostic value. So CT scan or perhaps ultrasound can be used, but not PET-CT, except if transformation is suspected, then a PET-CT can be of help to to identify the most hot lesion on the PET-CT to be biopsied to see if there's a transformation to an aggressive lymphoma. So this is the diagnostic part, and then we switch to treatment. And first of all, we only treat Waldenstrom patients when they are symptomatic, because sometimes Waldenstrom patients are diagnosed when they're asymptomatic. And because we can't cure this disease, we are not treating asymptomatic patients, and we are only treating symptomatic Waldenstrom patients. And I think in every guideline you can see which are the symptoms of Waldenstrom's. But I would like to stress that also fatigue can be a very disabling symptom of this disease. And when you start treating, please always see if there's inclusion in the clinical trials possible, because of this rarity of the disease, we do not have many randomized trials or other types of trials in this disease, and therefore I think every inclusion will help to learn more about this disease. But if that's not possible, then if you have to act fast because, for example, there is hyperviscosity or your IgM is very high, above 40 grams per liter, or you have a very bulky disease that's threatening your patients, then you could think about plasmapheresis in the case of hyperviscosity, of course, but also to start treatment immediately. And fast-acting drugs are bendamustine and bortezomib dexamethasone, but also the Bruton tyrosine kinase inhibitors are very fast-acting drugs. So you can use them all three. What's more easy in your clinic to have a fast response. Importantly, the rituximab is not to be given in patients with very high levels of IgM, so above 40, or patients with having a hyperviscosity syndrome, because they can increase your IgM levels and then you can put your patients in danger. So only use rituximab when the first responses are there and there's no risk of viscosity anymore. If we have very vulnerable patients, then perhaps chemotherapy is not the best option. And at the moment, we do advise rituximab monotherapy, but also most of the Bruton tyrosine kinase inhibitors, such as ibrutinib and zanubrutinib, can be given to vulnerable patients with a high age, elderly age. And also sometimes bortezomib is still a drug that can be given to these patients. But I think most patients will fall in the middle category. That's the remaining patients. They can be treated with chemotherapy consisted of dexamethasone, rituxan, and cyclophosphamide. And with this regimen, you give a regimen that is very doable, very effective, and with a fixed duration. And we do feel that most patients still like this option for them. And it's also one of the most cheapest options that we have. So that's also very important in the healthcare system, that we look out for the treatment regimens that can be also effective, tolerable, but also not too costly to many patients. So a very unusual treatment aspect of Waldenstrom's disease is when we give rituximab. So rituximab is very important in this disease, so we should always try to give it. But you can have a rituximab flare, and that means that you have a rise in your IgM levels after the administration of rituximab. This rise can prolong for a long time, so it can be there for around 4 months. And previous publications stated that it can be seen in around 50% of patients. Of course, when you combine rituximab with other drugs, sometimes you don't see it because there's also already a decrease of your IgM component. So what are the risks of rituximab flare? It's, of course, hyperviscosity, and that can be a very dangerous and an emergency symptom in your patients. But you can also have worsening of your IgM M protein related complaints, such as neuropathy, hemolysis, or your cryoglobulinemia. So that's why you should be aware of this phenomena and try to, if you think you are going to get in problems, delete or not give the rituxan in the first cycles of your treatment. We do think the rituximab flare is caused by interleukin-6, and it's a response to the stimulation of bystander immune cells, including monocytes that are in the bone marrow, surrounding your Waldenstrom's LPL cells. But the exact cause is not clear, and it's very typical of Waldenstrom's disease and not seen in other non-Hodgkin lymphomas. Another unusual treatment aspect is the rituximab infusion-related reaction, the IRR. So in the other non-Hodgkin lymphomas, you can of course have a reaction to rituxan, like you can have to all the other monoclonal antibodies. But normally when you give it a second time or third time, these reactions will disappear and are not a problem anymore when you continue with rituxan. But in Waldenstrom's disease, it's different. You can have a very problematic first infusion, but with each infusion, it becomes more and more problematic. And in total, 7% of patients, so that's quite a lot, can't tolerate rituxan at all, and you have to stop giving this drug to the patients. We don't know exactly why this is happening. Perhaps this is also one of those typical immune effects that we see in Waldenstrom's. But please be aware of that. And you see on the right of this slide, you see all the symptoms that can happen to these patients, including anaphylaxis, chills and rigors, highs, hypertension, and shortness of breath. So there are serious symptoms that sometimes forbid to proceed with Rituxan in this patients group. Also very common in Waldenstrom's is that they are much more sensitive to chemotherapy-induced polyneuropathy. They already can have polyneuropathy at diagnosis, but when you give neuropathy-inducing drugs, they will increase, these symptoms will increase a lot, and this is very disturbing to patients. So at all costs, try to avoid vincristine, but also already with bortezomib, this can be an issue. And that's why in the Netherlands, we started a trial in relapsed or refractory Waldenstrom patients combining ixazomib, so that's a proteasome inhibitor that's not inducing polyneuropathy, combined with sub-Q Rituxan and dexamethasone in these patients. And this study was published in the JCO last year. And within this trial, we try to follow the chemotherapy-induced polyneuropathy with special questionnaires for our patients, and they were created at baseline after cycle 4 and after cycle 8. And I think it's very important to do this in Waldenstrom patients if we are trying new drugs in them, to have a more clear understanding of this side effect. And what you can see on the left, that indeed ixazomib did not induce an increase in the neuropathy scores, so that's in that sense was a very safe drug. It was also an effective drug, the combination regimen, but if you see at the progression-free survival curve, it was not that great. And also in the maintenance phase, when switching from ixazomib to rituximab maintenance only, you saw a very high relapse frequency. And therefore, I think this, in the end, this is a very nice treatment schedule, but not that effective as we wanted it to be. Very important is that we have now a global questionnaire that represents the patient's voice. That's the cartwheel or the whimsical questionnaire that can be that every patient can see in the portal, and they can add their own side effects, symptoms, and also treatment data in this cartwheel or whimsical questionnaire in this portal. And this is already publishing a lot of interesting data on the effect that this the diagnosis and the treatment of this disease has on patients. So I would like to ask every patient, if you do speak English, can understand this cartwheel questionnaires, to log into the whimsical portal and to see if you can add to this very important global initiative. Another patient voice was examined in Dutch patients and was published also this year in Cancer Medicine. And in that aspect, we asked 214 Dutch patients to do a discrete choice experiment. So what does this entail? It entails that you get several questions, and in each question you have to choose between treatment A or treatment B. And these treatments are they differ in all the sides and in different aspects that are listed on the left. So how effective is the treatment? What does the treatment look like? Do you have to go to the hospital, or can you do it at home? What are the adverse events you can have with this treatment? Do you have a risk of another cancer in the future? And what type of agents are used? And every time a patient has to choose, I prefer treatment A or I prefer treatment B. And if you continue this for several treatments, then you can have a clear understanding in what types of aspect of the treatment is very important to patients. And in this paper, the Dutch patients presented that efficacy, so meaning a high 5-year PFS rate, was the most important attribute. but after that, followed by a low risk of future secondary malignancies. So that's perhaps also against the use of chemotherapy in these patients. And neuropathy was the adverse event they most wanted to avoid because it's very disabling to them. And patients did prefer a fixed duration IV or sub-Q treatment in the hospital. And they like targeted treatment better, opposed to chemotherapy or an ongoing oral regimen. So also the fixed duration treatment was something that's very important to the patients in this discrete choice experiment. And going to continuous oral treatment, I think the Aspen study is a study that's one of the most important studies that has been done in this patient group. And this Aspen study compared zanubrutinib to ibrutinib in both MYD88 mutated patients, and there was also a slight subgroup, only 28 patients in the wild type patients, and I won't present those at the moment. But if you can see that arm A contained 102 patients treated with zanubrutinib, and arm B, 99 patients treated with ibrutinib, and they were both treated with their standard dose of those drugs. Stratification factors were the 64 mutation status and the number of prior lines. The primary objective of the study to see if zanubrutinib was better than ibrutinib in the complete response and VGPR, so very good partial response in patients with the MYD88 mutation, but also to compare other efficacies, clinical benefits, and tolerability and safety in these patients. What you can see is that the median age was 70 years old at inclusion, so that's very good. An elderly population up to 90 years old. And the prior lines, it was given to around 18% of patients as first-line therapy, but most patients in this trial included had 1 to 3 prior lines, and most patients were MYD88 had a MYD88 mutation and were 6E4 wild type, so that was around 90% of patients. Here, this is the primary endpoint, so the intention to treat, and you can see that the CR and VGPR rate did differ a bit between the two groups, with a higher VGPR rate in the zanubrutinib group, but this was not statistical difference. So the primary endpoint of this study was not met, and there were no CRs in this study. This is the progression-free survival. So here you can see the in months the 3.5 years. You can see that there's some difference in the PFS favoring zanubrutinib, but also this was not statistically different. So ibrutinib and zanubrutinib are comparable in the progression-free survival curves in this study. However, there was a difference in adverse events, and this is a graph in which the red bars is and the blue bars is ibrutinib, and you can see in the first year of treatment there was already more atrial fibrillation in the ibrutinib group. Hypertension was the same. There was more diarrhea in ibrutinib, a little bit more bleeding, but less neutropenia, and the same amount of infections. But if you go to the later years of treatment, so this is the second year and this is the third year, you can see that the atrial fibrillation rate is still increasing in the ibrutinib group. The diarrhea of the hypertension is increasing. The diarrhea is a bit less, but bleeding is seen more in the ibrutinib group, and the neutropenia, they are not such a problem anymore as they were in the first 2 years, and also the infection rate is higher in the ibrutinib group than in the zanubrutinib group. So I think at the side effects level, I think the zanubrutinib does perform better than is seen in ibrutinib, except for the neutropenias. But ibrutinib is on the market a bit longer, and we do know now how we can use ibrutinib perhaps a bit better. So this is a very interesting paper from published in January this year, in which a group assessed how many patients needed dose reduction for ibrutinib. So there were in total 383 patients. Included in the analysis were 353, and 96 of those needed dose reductions because of side effects of ibrutinib. And most patients needed only one dose reduction, but there were also patients that needed 2 dose reductions. So the big question is if this is detrimental to the effect on the Waldenstrom's disease, and perhaps we are losing responses in these patients, but that's not the case. So here you see the PFS curve of these patients. Blue is no dose reduction, and the red one is with dose reduction. And you can't see that there is a decrease in progression-free survival in the patients with dose reduction. So in ibrutinib, you can safely dose reduce if that's needed for side effects of these patients, in these patients. Another very interesting trial that was just published is the ICWM1 study. This is a study in primary diagnosis of first-line treatment. And this study wanted to investigate if the DRC treatment, which is standard treatment in most patients, can be improved by adding bortezomib to the DRC regimen. And also in this study, each arm had around 100 patients. So this is also a very big study in Waldenstrom terms to evaluate. So this study is just published in the JCO. It's published online just now. And here you can see that for the primary endpoint, which was overall response rate, there was no difference. So this is in that sense also a failed study that did not meet its primary endpoint, because the overall response rate with DRC was 91%, and with bortezomib DRC it was 94.8%. Perhaps there was a little bit more deep responses in adding bortezomib to the regimen, but we do not know. This normally does not translate to a better overall survival or progression-free survival in Waldenstrom patients. And that was also the case in that study. If you look at the survival curve at 2 years, where you still have some patients in this included, you can see that, here it is, you can see that the progression-free survival did not differ in these patients. So in the sense that bortezomib did not add much to the efficacy of this of first-line DRC treatment, and DRC treatment still remains the first choice of treatment in patients who can tolerate it. For relapsed patients, perhaps a very new, interesting drug is coming, and that's Pantoclex. That's published in one paper until now. It's a small study in 31 patients in relapsed or refractory Waldenstrom patients, which all had the MYD88 mutation, and half of the patients also had CXCR4 mutations. This was a bit of a younger group, 66 median age, but up to the age of 80. And what the authors did is that they increased the dose of Pantoclex like we do in CLL. They start with a starting dose of 200 milligrams, and then up to, after 1 week, up to 400 milligrams. And they also went up to, from that to 800 milligrams for up to 2 years. And after that, after 2 years, the treatment stopped. And then they did event monitoring. Here you can see a slide on the efficacy of Pantoclex monotherapy, and you can see that the overall response rate was 84%. So that's very good for patients, I think, treated with many other drugs. The relapsed patients perhaps did a bit better than the refractory patients. And also, if you have more prior lines, more than 3, you did a bit worse than when you give it earlier. That's what we see in all treatments, of course. Having a prior Bruton tyrosine kinase inhibitor did not differ that much. And also, very importantly, the mutations didn't differ. So having the CXCR4 mutation did not negatively affect the treatment response to Pantoclex, and also the prognostic score did not matter that much. So this is very promising drug. I think also the side effects were not very high grade. Perhaps infections was the most important one. And here you can see the PFS curves, and also very striking here, if you stop treatment at 2 years, all the relapses are coming. So I think in future trials of venetoclax, it's important that we continue with the venetoclax treatment. But this is a very promising first paper on this interesting oral drug, targeted therapy, but not a fixed duration. But I do think that continuous treatment will also be necessary in these patients at the moment. One last question about treatment is rituximab maintenance. This is a very simple slide. It's from an ASH abstract presented in 2019, and until now, no formal publication has been published. But here you see 2 curves about from patients that had chemotherapy fixed duration, including with rituximab already in the treatment regimen, and thereafter were randomized to rituxan maintenance or no maintenance. The blue line is rituximab and the red line is no rituximab. But you can see this is the PFS curve. You can see there's no difference. So at the moment, rituximab maintenance is not recommended in Waldenstrom patients, and we are all waiting the publication of this study, of course. So this is the end of my presentation. My take-home messages are that it's very important to make the correct diagnosis of Waldenstrom's, because it has so many implications, not only for treatment choice, but also for the typical side effects of treatment, and that you have to follow up your IgM instead of PET-CTs like you do in other lymphomas. And with that, I would like to thank you so much for listening to me. I would like to acknowledge the Dutch Waldenstrom Task Force, who's helping a lot with all the publications from our group to help understand this disease. And of course, also the global Waldenstrom community, which is a great, warm, welcoming community. And I would like to invite you all to come to the Waldenstrom workshops, which are organized every 2 years, and in which you can learn much more about this fascinating disease. Again, thank you very much.
Thank you very much, Monique, for this really beautiful and really comprehensive overview. I think you have managed in less than 45 minutes to give us a journey in time from the diagnosis, a history of Waldenstrom, until the most recent data. I've just seen even pre-published papers in JCO that you have included. So thank you very much. We have a lot of questions. The list is huge, actually. So I'm not sure we'll be able to handle all of them, but I'll try to structure them by topics. Some of them are overlapping. So first question regarding the diagnosis, Monique. How do we distinguish between Waldenstrom macroglobulinemia or disease and IgM MGUS?
Well, I think I presented 2 of the different classifications that we have at the moment. And so the WHO clearly states that a difference is the infiltration percentage, so less than 10% or more than 10%, while the ICZ classifications states that you have to look for aggregates instead of some diffuse infiltration in your bone marrow. At the moment, it's not clear which one to use. I think at the moment, the most commonly used is the WHO one, so with the 10% cutoff. But it's important that with patients which have many complaints and you only have like 8% or 6% of infiltration, that you do think about treatment, so that you don't have this cutoff of 10% as a definite one. So below 10%, you can't have any symptoms, because you can, and then you should treat. For example, with IgM and amyloidosis, most of the patients have less than 10% of infiltration. So I think it's still a debate. I don't have the final answer, but in our country, we still use the 10% cutoff, like the WHO is also applying.
Okay, wonderful. I think that was clear. Another question related to the diagnostic workup, which is about neuropathy. what are the recommended tests when a patient is complaining from a neuropathy with a diagnosis of Waldenstrom?
Well, in Waldenstrom disease, the typical pattern of the neuropathy is that it's a demyelinizing type of neuropathy. So if you send the patients to a neurologist and they do an EMG, they normally can differentiate between that. But there are some failures in that, especially in patients with a long-lasting neuropathy. Then you go from the myelin to the axon, so you can have an axonal neuropathy while you have Waldenstrom's disease. So it's not black and white in total. And I must say, I do like just listening to our patients. So they are telling you how worse their neuropathy is. Is it only sensory? Is it also with motor neurons? So do they have problems with walking? Do they have problems with their balance? That's very typical in Waldenstrom patients. So I do feel that with a good medical history, you can find out, and the neurological testing with EMG can help differentiate in the beginning, but it's not a black and white one, and I don't recommend several testing ahead of that. We are trying to solve if we can have better questionnaires for these type of patients, but neurology is not hematology. You know, we are that we have IgMs and we can do bone marrow biopsies and we can look at all those things, and neurology doesn't have that. So it still needs a lot of investigation to be more precise in that field.
Wonderful. Another question related, I think, to the complications of Waldenstrom. This is Dr. Sanjeev Yadav, who's very loyal to the ICH, asking whether amyloidosis is a common complication in Waldenstrom.
It's not. We don't think it's common. We don't have good registries on it, but we don't think it's common, but it can happen. And if you flip it around, if you look at all the amyloidosis patients, then around 6% have IgM type of disease, so an LPL or Waldenstrom's type of disease. So it can happen. It's not very common, but I think it's good, especially when you are seeing an IgM-MCAS patients or any MCAS patients, to look out for amyloidosis. So do an NT-proBNP, look in the urine if there's an increased rate of albumin in the urine. So look out for this disease, because when you have amyloidosis, early diagnosis is one of the most important predictors of survival. So it's not common, but if you feel something odd is with your patient, too many complaints for Waldenstrom or IgM-MCAS, please look out for amyloidosis as well.
Okay, wonderful. I think your message is always clear, and I learned very well that we need to listen to the voice of the patient. And I like this tool that you're providing for patients on the internet. And hopefully it will be translated to different languages, because obviously, unfortunately, not all patients are fluent in English. But this is really a great initiative, and I'd like to thank you for this. Let's move now to the therapeutic arena, because this is really exciting. One question is about how do you manage a patient with a high IgM level, 40 gram per liter, but no bone marrow involvement, no symptoms, and how do you manage and monitor such patient? Because the amount of IgM sometimes is frightening if it keeps on increasing without symptoms.
It is, but a bit strange of this question is there's a high IgM but no bone marrow involvement, but the cells are somewhere. So if there's marrow, perhaps there is some lymph nodes, but that would be very atypical. So perhaps a repeat bone marrow can help in these cases. But a high IgM can be frightening, that's true. And we used to have a blood test for hyperviscosity, because that's the frightening thing, the hyperviscosity. But we don't recommend that because those tests are not very good in predicting who's getting problems or not. I think eye examination is the most important one. So if you have a patient with this high of IgM, send them to the eye doctors to have an eye examination to look for early signs of hyperviscosity. And if you are going to get too frightened, or your patient is going to get too frightened, I think above 40 grams per liter can be a sign to start treatment. Skip the rituximab, like I explained in the presentation, but there are patients who are being treated with this level because patient and doctor can't tolerate the stress anymore. But I must say there are patients with 60 grams per liter that don't have any symptoms as well. So it's a nerve game, I think, a bit, but safety of the patient, of course, is the most important one.
Okay, so let's talk about the safety. Actually, first, we have a comment and a question from the same colleague. He or she's saying that rituximab doesn't really improve neuropathy in Waldenstrom. Should we favor BTK inhibitors, especially zanubrutinib, in these patients?
Well, that's a great question, because it's one of the topics I really want to investigate. We do know now that rituximab is not helping neuropathy that well, but we don't know if the BTKIs are doing that as well. There are some case reports, some signs from in the literature saying that, by the way, we had some patients with neuropathy and they said they did better. Well, that's very great, but a systematic view on this is lacking at the moment. So we are still have to do some work in that, to have a bigger group of patients with neuropathy and follow them up in a very strict way to see if they really are improving. I think it will be very difficult, because a neuron is not like a blood cell or a hematopoietic stem cell. It doesn't divide that much. So improvement in your neurology is always difficult. So I don't know if we will have great drugs in the future that will help us with the neuropathy problems that our patients face. Perhaps it will be complement inhibitors or something like that in the future, because IgM can activate complement, but we don't know yet. We are starting a study in the Netherlands for patients with IgM with an anti-MAC antibody, high titer, and zanubrutinib this year. So perhaps then we will know a bit more. But neuropathy is one of the most dreadful side effects, but also symptoms of this disease. And I'm afraid we still don't have very good answers to that.
Okay, well, no, I think that give us some room for further research despite all the advances, and this is really great. Another question about the treatment and BTK inhibitors. So I'm reading, most Waldenstrom patients are elderly, and usually elderly patients do have cardiac problems, and they would receive frequently anticoagulants, but also aspirin or similar drugs. So given the risk of bleeding, which is high with ibrutinib, shouldn't we favor zanubrutinib for all of these patients?
I think we should. Yeah, I'm quite clear on that. If you look at the results from a randomized phase 3 trial, I think it's clear that in that regard, the side effects of Zanu are much better than ibrutinib, and I would favor zanubrutinib. Watch out, it has more. It's a capsule, but it's not a tablet. But you have to take 4 in a day instead of 1. So it's perhaps that can be a problem to your patient. But looking at the side effects, and especially the bleeding and the atrial fibrillation, it's safer. Yes.
Excellent. Thank you very much. We'll take one last question. Any role for CAR T cells in Waldenstrom?
Well, I don't know. There's a publication with only 3 patients, and 2 of them did not respond that well. I don't think this disease, CAR T, will be an option for many patients. Perhaps the bispecific antibodies will be a better choice to investigate in Waldenstrom's. CAR Ts, perhaps, but only for a small portion, and we still don't know if they work really well in this disease.
Well, thank you very much, Professor Minnema. It is 7 p.m. sharp in Utrecht. I think we've been perfectly on time. Thank you very much all of you for joining us today for this lovely webinar dedicated to a fascinating disease which has witnessed really some amazing advances, including randomized phase 3 trial, which was something unbelievable 10 years ago. We managed to randomize ibrutinib versus zanubrutinib, rituximab versus other combinations. This is really very, very exciting. Thank you all. Apologies, we could not handle all the questions, but I'm sure Professor Minnema may reply to you by email in case there is really a burning questions. But for the time being, I'd like to say goodbye, but please don't forget the ISCH activities always continue, and we're trying to deliver the best education, hematological education without borders. And tomorrow, I think we do have a lovely junior club that will be presented by young fellow colleagues from Yale. And please stay tuned, and wherever you are, stay safe and keep well. Thank you very much.